الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. We're still talking about infection control. This lesson is about procedures for managing an exposure to blood or body fluids or substances by Professor Mahmoud Hani Suleiman. This includes sharp injuries, including needle stick and splashes into mucous membranes or bare intact skin. It is occupational hazard. It is present as an occupational hazard. It is occupational hazards from sharp injuries, including needle stick injury, and other blood or body fluids incidents include human HIV, HPV, and HCV. Exposure equal an injury that involves direct skin contact with body fluid listed and there is compromised skin integrity. يبقى compromised skin integrity as an open wound, abrasion, or dermatitis, or if there is direct mucous membrane contact. For exposure to skin, if large area of skin exposed and longer time of contact, longer duration, the more important it is to verify that all relevant skin area is intact. Infection control protocols. All health services must, this is a must, develop their own infection control protocols. They must develop their own infection control protocols in a written form for communicable diseases, including clear written instructions on appropriate action to take in event of an exposure to blood or body fluid substances, needle stick injuries, other blood or body fluid. You can use this lecture to do so. Here I want to make a stop. I want to explain any procedures, not only infection control, any procedures inside a hospital or clinic there must be a protocol for it. Suppose how to inject DPT vaccine. This must be written protocol for it. I'm here want to say a story. Once of our physicians at the very recent hospital was going to make dress for an eye in ophthalmology department. The nurse was from Emirat. She said to the physician, "This is wrong. You are doing wrong. In Emirat we do so and so." And another physician told me this and say, "How dare this nurse to say so?" Okay. Any nurse can talk to the physician about what he is doing between her and him. But both the nurse and the physician were wrong. Why? Because for this procedure, there must be a written protocol for this special hospital. The protocol not of Emirat, not of America, not of Great Britain, not for MOH at Egypt. No. The protocol must be for this particular hospital, not for another hospital in the university. They were wrong. This physician, being a consultant, a professor, must put protocol for every procedure he is doing inside the clinic or hospital. And this nurse must ask the administration of the hospital to put this protocol for each procedure, not the protocol for Emirat. So all health services must develop their own infection control protocols and any other procedure inside it. Incidents. This is the definition of incidents. Involving either patients or healthcare workers, including physician, medical officer, or other suitably qualified professional to be connected. Lab, which will process emergency specimens. This is where incidents can occur. Pharmacy, which stocks prophylactic medication. Procedures for investigating circumstances of incidents. So there must be procedures for this incident when it happened. Procedures, and it must be written. Procedures for investigating circumstances of incident and measures to prevent recurrence. This may include changes to work practices, changes to equipment, and or training. Details for prompt reporting, evaluation, counseling, treatment, and follow-up of occupational exposure to blood-borne viruses. So there must be written details for prompt reporting, evaluation, counseling, treatment, and follow-up of occupational exposure to blood-borne viruses. Immediate action. Treatment protocols should include removal of contaminated clothing, thorough washing of injured area with soap and water. Affected mucous membranes should be flushed with large amounts of water. Eyes flushed but flushed gently. Exposed person must report any occupational exposures immediately. The exposed person should have a medical evaluation, including information about medications they are taking, underlying medical conditions or circumstances. Post-exposure prophylaxis, PEP, and counseling should be available and offered. Post-exposure prophylaxis treatment should be available during all working hours. Treatment should be available during all working hours and on call after hours, e.g. through on-call infectious disease physician. Immediate action continued. Patients or others exposed to blood or other body fluid or substances must be informed of exposure by a designated professional while maintaining confidentiality about source of blood. We will not tell him the name of the source. Baseline serum should be collected from patient and expert counseling provided on implications of what has happened. PEP and appropriate long-term follow-up should be offered where applicable. Patient or source refusal for testing. If the patient or source refused for testing, serum storage should be documented. We take a specimen from him and store it for if we need it. Exposure incidents that do not occur in a health service should be reported to general practitioner or emergency department at nearest hospital. Now, management of the source individual. Persons whose blood or body fluids are the source of an occupational or non-occupational exposure or other injury should be evaluated for infection with HIV, HPV, and HCV. Information available in medical record or from the source person may suggest or rule out infection with each virus. If the source is known to have HIV infection, then information on stage of infection and current and previous antiretroviral therapy should be gathered, used in deciding the most appropriate regimen for post-exposure prophylaxis. If HIV, if HIV, HBV, or HCV status of source persons is unknown, then the source person should be informed of the incident and their consent sought to test for these viruses with appropriate pre and post-test counseling. Their consent to have the information in their patient record used should be sought also. If consent cannot be obtained, for example, if the patient is unconscious or unwilling to consent, then procedures should be followed which comply with legislation. The source individual should be tested as follows at time of injury: HIV antibody, HB surface antigen, HCV antibody. If HCV antibody test positive, then HCV PCR performed to test for HCV RNA. Transmission is less likely to occur from a source who is PCR negative. Status of the source individual may be known at time of incident. In this case, affected person managed as described below under immediate management. If source is unknown, case should be managed as described below. Source individual unknown. Reasonable efforts should be made to identify the source. If the source remains unknown, appropriate follow-up determined on an individual basis depending on type of exposure, likelihood of source being positive for a blood pathogen, prevalence of HIV, HBV, and HCV in community. Management of the exposed person. Immediate care of exposure site. Contaminated clothing removed. Injured area washed well with soap and water. An antiseptic could also be applied. Any affected mucous membrane flushed with large amounts of water. If eyes contaminated, they should be rinsed gently but thoroughly with water or normal saline while kept open. Evaluation of exposure. Exposed person should be examined to confirm nature of exposure, counseled about possibility of transmission of blood-borne disease. Evaluation and testing of exposed person. Exposed person should have a medical evaluation including information about medications, underlying medical conditions or circumstances. All exposed people assessed to determine risk of tetanus. Depending on circumstances of exposure, the following may need to be considered: tetanus immunoglobulin, a course of adsorbed diphtheria tetanus vaccine, adult formulation, TD vaccine, or TD booster. Exposed person tested for HIV, HCV, HBV, hepatitis B surface antigen, at time of injury to establish their serostatus at time of exposure. Expert counseling on implications of event, PEP, appropriate long-term follow-up should be offered. An option is that may be offered to healthcare workers who do not wish to undergo testing at time of exposure is to have blood collected and stored but not tested and returned for a minimum period of 12 months. If the source person is HIV, HBV, and HCV negative, no further follow-up of exposed person is necessary unless there is reason to suspect source person is seroconverting to one of these viruses or was at high risk of blood-borne viral infection at time of exposure. If source is positive for one of these viruses, pregnancy testing offered to women of childbearing period who were and whose pregnancy status is unknown. This table summarizes management of exposure to blood and body fluids. Immediately after exposure, as soon as possible, same day, 1 to 3 weeks, 3 months, 6 months. Immediately, first is relief from duty, risk assessment, post-exposure prophylaxis if significant injury was. As soon as possible, within one same day, source assessment, documentation of exposure, prevention of transmission and exposure, baseline serology, referral to specialist, support of significant others. 1 to 3 weeks post-test counseling, occupational health and safety review. 3 months pre-HIV test counseling, follow-up serology for HIV, HBV, HCV. 6 months follow-up serology, HBV, HCV, HIV if PEP taken. Post-exposure counseling. A specialist with knowledge of blood-borne infections should undertake follow-up if it is demonstrated that a person was exposed to a blood-borne pathogen. They should not donate blood or semen or organs or tissue for 6 months and should not share implements that may be contaminated even with a small amount of blood, e.g. razors or toothbrushes. For HIV, HBV, they should be informed of the risk of transmission to sexual and injecting partners for a 6-month period and counseled about issues of safe sex and safe injecting. If PEP is indicated or there is risk of acute infection with HIV or HCV or HBV, advice should be offered on pregnancy and breastfeeding based on individual risk assessment. In case of HIV patients, advised of remote risk seroconversion up to 12 months post-exposure, particularly if a specific PEP was undertaken. Follow-up for the exposed persons. If the source person is seronegative for HIV, hepatitis B surface antigen, and HCV, baseline testing for further follow-up of healthcare workers normally is not necessary. If source person has recently engaged in behaviors that are associated with risk for transmission of these viruses, baseline and follow-up HIV antibody testing of HCV should be considered. وفي النهاية لا أجد إلا أن أقول لكم thank you والحمد لله الذي بنعمته تتم الصالحات.